Hello. So hi everyone, I'm Murray. I'm a GP from South East London. And
I'm Sukh. I work for Bexley CCG as Assistant Director of Primary Care.
We're going to do a bit of double act. Sukh's the smart one with the proper job, hence the tie. I now work for a tech company, so I'm allowed not to wear a tie anymore and have my shirt untucked. So apologies for the slightly dressed down look. So let's go.
So apologies that you haven't got to take that, but you've got us instead to guide you through this presentation. I'm just going to start with just an overview of where we are in Bexley and the challenges that we face. We have significant challenges around primary care, particularly looking at sustainability and resilience of our healthcare provider in general practice, recruitment and retention of workforce. And we have 23 practices that are split across 3 different localities with very differing needs and challenges. Also in Bexley we have no acute trust, which also causes a challenge for us, particularly around how patients can navigate around the health and care system and knowing which services to access and when. So where we ended up was that we really identified that we needed to do something to help kind of support the system. So we looked at the eConsult model and how we implemented this not only in our GP practices within our urgent treatment centre and developed our own app which created a front door into online services in Bexley. But I'll pass it to Murray and talk through the patient journey.
Cool. So I'm just going to explain the product really, because this is kind of where we came from and kind of feeds into what we do in Bexley. So it's all very well explained to you what we've done in Bexley, but you need to understand what I mean by online consultation first. So I guess everyone, when they think it's online consultation, instantly thinks video consultation. This isn't quite video consultation. We tried, this platform evolved out of a group of general practices, and we tried video 4 or 5 years ago, but found that it doesn't really save any time. Still need 10 minutes of a patient, 10 minutes of a doctor. And we also found that the infrastructure at that time wasn't great. So that really annoying bit on a video call where you're trying to connect, when you've only got 10 minutes, you're going to waste 2 minutes trying to connect to the patient. So for us, it's not that video's never, it's just that we need to fix the infrastructure first, and thank you to NHS and Hancock because we're doing that now, getting fast broadband in. But back then we didn't, so we came up with a different idea, which is let's gather the history in the patient's time, push that history through to the clinician then makes a decision. So I'll just walk you through the patient journey. So the routing is through the practice website. Now this is a practice website from Bexley. We actually also get more activity coming through on a mobile device, but this is the website. Now practice websites, I don't know if anyone's been to their practice website, they don't tend to be brilliant. Most practices just use them as a kind of information repository, and most patients only use them because they Google the practice name, because they can't remember the phone number, and then ring the practice. Okay? So we always say to practices, look, this really has to be very dominant on your website, so a bit prominent position, and hide your phone number. Not in a Virgin Media type, can't find your phone number type way, but more in a kind of put it on the contact us page. Because if you've got a patient on your website, keep them on your website. The patient will then click through, and they'll either, a lot of patients coming into general practice know what's wrong with them, so they know their condition, or they might want general advice, they've got symptoms, or they might want administrative help. So we offer them those choices, and they can search by condition, or they can search by body part. And then we don't just route everything through to the clinicians. We also then will surface self-help content that links through to NHS choices. We can postcode finder, they can find the nearest pharmacy, and we can surface local services. So it's very configurable. Now, then if a patient clicks this bottom button, we then take a history. So we've got the same kind of red flags that they use in 111, you know, to rule out, kind of get the emergencies out of the way, and throughout the site there's other red flags as well. Then we take a history, much as I would take a history if the patient is in front of me. But we're doing that in the patient's time, 24/7, and then we push that through to the practice. Don't worry about the detail, but that's the sort of report that lands in the clinical system at the GP practice. And then from that, the clinicians make a decision. So, clearly, if the patient's interacting with any of this self-help, signposting, access local services, the practice doesn't have to do anything, so that's all good. That's patients that aren't coming in. If they do come through and take a history, we know you can then close about 40% of those consults down without even speaking to the patient. So uncomplicated UTI, I can issue a prescription, send it via EPS to the pharmacy, send the patient a message to the patient pharmacy. So it's good for patients, good for clinicians. About 30% we have to bring back, but that's often just to tell the patient the plan. And about 30% we have to bring in, but we can triage those. So that's the idea, and that's what we've done and deployed at scale in Bexley. And then the other bit, as referred to, we've also changed the journey with an urgent care setting. So, and we did this because all the practices are signed up to the primary care platform. And we thought, hey, here's a really good opportunity to change how urgent care works. And can we change that journey? They don't have an ED, but they do have a 24/7 urgent treatment centre. So, the traditional journey, you book in, you wait for a while, see a triage nurse, takes a history, does some obs, wait for a little bit longer, and eventually see a clinician. And everyone's familiar with that journey when you walk in. And what we've done in Bexley is actually you walk in and you interact with an iPad. There's a whole bank of iPads, so there's never a queue. Patients will walk in, and at the iPad it asks them who they are, and then it asks them why they're there. So it starts taking a history from them. And we're also working with some technology that can automate the obs, so we can then actually get obs plus history. You can then put the sicker people to the top of the queue. So we're starting to risk profile right at the front door of the UTC. And actually, we can then push that information into Adastra, which is the clinical system we use. Advanced were fantastic, really helped us to kind of get that all going, but that information is then colour-coded within Adastra, red cases, sick people at the top, less cases are kind of P5, lower acuity ones, coded differently at the bottom. So we've done that. That is live. It's been going for a year now. 99% of patients book in on an iPad. Very simple user interface, average time spent on the iPad, 4 minutes. But the bigger thing, okay, this is kind of what we're going on to, is actually we're saying to every patient who comes through the door, next time, do this from home, okay? So this is about the kind of starting to influence the behaviour change. Because actually from home, next time, you could go to your practice website or download the NHS Online app, which was a kind of precursor to the NHS app. We can signpost you to self-help pharmacy. If your need is general practice, we can route that consult through to your GP, because we've established that connection, we can get it in front of your own GP. Or if your need is more urgent, you hit a red flag, actually we can push that information into the urgent care system. So you're kind of starting to say to people, look, start your journey from home. And this is not going to happen overnight, okay? But it's just starting to actually influence behaviour change. So that's the kind of the products, and that's what happens in Bexley now across both primary care and urgent care. I'm going to hand back to Sukh now just to talk a bit about what we learned from implementation.
Thank you. In terms of where we started with, in terms of implementation in Bexley, we initially kind of faced concerns about actually what this meant to practices, what this meant to patients. So there was concerns about workload burden and already stretched resources, the potential to create demand rather than alleviate it, the ability and headspace to actually have time to implement what we wanted to do, with already finite resources, and the potential for patients to circumvent the existing pathways that are in place, so they could potentially find their ways around the system, which maybe wouldn't be in the best interest of them or for the health and social community, health and care community. There's also a concern about the inequality of access, particularly for the elderly and deprived. So again, we've got different localities that have very different makeups of their patient cohorts. So there were a lot of concerns about actually how these would work for them. So we initially started with the patient engagement. So we did some real good work with patient council from the outset, and they were involved in kind of design of our app. But also their views were taken on board of actually how we can make this work for them as patients, but also for the practices that we're rolling out to. As Murray mentioned before, websites were a real big thing that we found was there's a real variability. So we worked on some standardisation of practice websites, and as part of that, making sure that the online consultation tool was prominent at the front of it. Comms was really key, and there's a lot of stuff that we did around an SMS campaign, appointment cards, and then a phone line message from a GP, as in the trusted voice that patients recognise, actually promoting this service to them. And we shared learning, so we kind of got some real kind of practices that really embraced this and got them to kind of circulate their learning with other practices as well. One thing we kind of underestimated initially was actually the role of reception staff. So we kind of did a lot of engagement with clinical staff, but actually to get this to work, reception staff were really key as a front door into GP practices. So they were able to promote it to patients at their time of need, and also try to help kind of move patients around that pathway. We also generated a lot of positive media coverage, so we got some from HSJ, Times, and there was a portion of ITV Tonight about what we've done with online services in Bexley. We also identified that there's different models that could be done with this. So one was a practice that kind of used it as a real triaging tool for their patients, and they operate a 2-hour turnaround. So if the patient submits an online consultation, they will get a response within 2 hours. It's also helped them to kind of meet the rising demands from patients, but also kind of signpost them to the right services for their online consultations. And as I said, we don't necessarily just stop there, so we're going to roll out iPads into our practices so patients have access within their GP practices to use online consultations. We're also going to do some work around adding local services to it, so it doesn't all end up back at the GP practice. We can signpost patients to the right services for them. There's integration with 111 that I know the eConsult team are working with, and alignment with 111. And in terms of development of primary care networks, we're looking at a potential e-hub model that we can do with our primary care network, particularly around how they can use it for their extended hours requirements. I'll pass back to Murray and run through some of the stats.
Just a couple of slides on utilisation, because I think that's the thing. I think online consultation is a new concept. So general practice tends to be fairly traditional, and everyone knows the kind of frustration of trying to get through on the phone first thing in the morning to try and get an appointment. And actually that behaviour change bit can't be underestimated, getting practices to change how they operate. Now what's worked really well in Bexley is we've got all of the practices live, and now we've got a couple of the practices that have actually really thought hard about how they're going to change their model and shift it. So we've got a lot of practices, what they'll do is they'll run a telephone triage model. So when you've got a 3-week wait for an appointment, you put on an urgent list of patients the GP has to ring back in order to get an appointment that day. And actually what then happens is you end up with a really long queue of telephone calls. So what works really well is shifting that telephone list online. And that's exactly what the first practice in yellow did. And fairly soon afterwards, sorry, green, fairly soon afterwards the one in yellow did the same. Now they actually switched from a walk-in model. So they had a kind of walk-in model, they were doing a few eConsults, testing it out. They then just basically turned off their walk-in, they turned off that tap and opened up the online tab and routed everything online. And some of the practices now, even the patients who say, well, I'm not online, which is the minority, they get a receptionist to ring them back and talk them through an eConsult. It just means that the clinicians then have a history for every single patient. So it's kind of happening over time and evolving and changing. And then this is just some of the data and some of what we've learned from the putting the iPads into the UTC. So as I said before, about 4 minutes average time to check in. It's never a queue. We haven't taken the humans out, so there's still receptionists, but what the receptionist role has changed. And what they do is those patients are a bit uncertain, they become the kind of care navigators. So they'll spot that, come around the desk and help people through who aren't as adept at using an iPad. We picked up a subarachnoid hemorrhage in a 24-year-old male within minutes of them arriving, just because he took a good history at the front door. It's the kind of case that would have sat there just with a bad headache, waiting for quite a long time potentially to see a clinician. So this has got great potential, and a success kind of it's been a whole team effort across Bexley working with patients, clinicians, and the kind of designers, the technologists to bring this all together. So last slide for a second.
So yeah, just to summarise the stuff that we've gone through. So in terms of implementation, we identified that there are a variety of ways of implementing it. It's not kind of one size fits all. We worked with engagement with patients and practices alike, so it's kind of make sure that we work with them, but also work with all practice staff. So it isn't just about the clinical buy-in; it's also about actually getting buy-in from the rest of the practice team. There was, in terms of promoting it, we did some sort of actually promoting it as additional method of communicating with the practice. It doesn't necessarily create additional demand. Promoting at the time of need was really helpful. So when we did the app rollout, we found that patients downloaded the app, but they hadn't actually recognised that when at the time of need they kind of forgot they had the app. So it's actually reinforcing that message that this service is available to them. Dispelling some of the myths that are out there about how it doesn't work with cohorts of patients. In terms of the feedback, so Murray went through some of the stats, but the really powerful messages that we get is actually the comments that we get back from patients as well, and we get monthly reports that actually show where it has and hasn't worked, and we can learn from that. So if there is some stuff that kind of is really working well, we can share that. But similarly, if there's stuff that isn't working well, we can look to see how we can try and change the way it's working in practice. I mentioned the reception stuff really key in terms of promoting it, clinical voice and leadership. We're using this to empower patients and take control of their healthcare. And we're just continuing learning from patient feedback in terms of how we develop this.
Cool. So that's it. I'll put our contact details up there. So if you've got any other questions, we've probably got like 1 minute for questions. So, but if there's any questions, honestly, write down our email addresses, contact us, follow us on Twitter, any way we take acceptable channels, omni-channel.